Good morning. On the behalf of the Egyptian Society of Arthroscopy, I would like to thank the committee of the SLAHOC for the kind invitation. It's a great honor to be with you and with this famous professor and doctor from all the world. My lecture today is about Laterjet Edyne Hybinette procedure for the management of anterior shoulder instability. In the past, arthroscopic Bankert repair was the gold standard method for treatment of all cases of anterior shoulder instability. But shoulder instability is not only Bankert lesion. There is other injuries like Hagel lesion, intrinsic injuries of the glenohumeral ligament, and complex capsuloligamental disruption. Also, there is important glenoid bony lesion, which may be either an avulsion fracture of the inferior glenohumeral ligament or maybe a true fracture of the inferior glenoid. Also, there is a famous heel sac lesion, which clinical importance depend on its size and site. Another factor that must be put under spot, which is a type of sport, high failure rate were found in arthroscopic Bankert repair with patients playing high-risk sports. The concept of bipolar bone loss changed from the term of engaging and non-engaging, which was difficult to be assessed preoperatively, to the on-track and off-track concept. To assess an on-track or off-track shoulder preoperatively and then find the right operation, we must do a CT for both shoulder and visualize the glenoid and the humeral head using a 3D CT. For the heel sacs, as we know, the site and the size matter. The more the defect is medial, the more it is important. So we use the term of heel sacs index, which is the sum of the size of the heel sacs plus the bony bridge between it and the rotator cuff insertion. We can also measure the glenoid width arthroscopically using the burr spot as a reference of the glenoid center, so we can measure the size of the glenoid defect. Also the heel sacs, as well the bony bridge between it and the rotator cuff insertion, can be measured with a graduated probe to calculate the heel sacs index. The glenoid tract must be larger than the heel sacs index to be an on-track lesion, and an isolated soft tissue procedure may succeed in such situation. But if the glenoid tract is less than the heel sacs index, so this heel sacs is off track, and the isolated soft tissue procedure will not succeed. So we have four probabilities. Either the glenoid bone loss is less than 25% and the heel sacs is either on track or off track, or the glenoid bone loss is more than 25% and the heel sacs is either on track or off track. Only in the first situation, an arthroscopic Bankert repair may succeed. In the second situation, we must add a remplissage for the heel sacs or to increase the glenoid tract by doing a bony procedure. In the third and fourth situation, bone block procedure is mandatory, and we may need to add a remplissage in the fourth situation if the bone block is not enough to increase the glenoid tract to be larger than the heel sacs, and the heel sacs still engaged after the bone block. The Instability Severity Index score introduced by Professor Dr. Pascal Boileau. He took his decision either to do Bankert repair or bony procedure depending on 6 factors: the patient age, the degree and type of sport, the shoulder hyperlaxity, and we should note that shoulder hyperlaxity is not always part of generalized ligamentous laxity. It is diagnosed by more than 90 degrees of external rotation of the shoulder at a side. The presence also of heel sac in external rotation in the shoulder X-ray, and if there is a loss of contour on the AP shoulder view. A score more than 7 means that there is 70% incidence of recurrence after isolated soft tissue procedure. Laterjet procedure is an anatomical repair technique used in which the coracoid process and its conjoint tendon is transferred to the anterior glenoid. Laterjet procedure was first described in 1954 by the procedure, but the procedure didn't take its repetition until its surgical technique has been modified and described by Professor Dr. Gilles Walsh, and he is the one who analyzed its principles, which are: number 1, the bony reconstruction of the anterior glenoid, which increased the glenoid arc, and this is the most important part. Number 2, the sling effect by lowering the inferior fiber of the subscapularis, which acts as a check rein against anterior-inferior translation of the humeral head. And number 3, capsular effect by suturing the coracoacromial ligament to the anterior capsule, reinforcing it. The Edyne Hybinette procedure has the same target of increasing the glenoid arc, but this time by using an autologous tricortical iliac crest graft. We all know the technique very well, but I would like to stress on 3 points common in the 2 procedures. First, to avoid the complication of graft non-union, we must do proper refreshment of the anterior glenoid as a bed of the graft we put. Second, to avoid complication of graft fracture. As we learned from Dr. Gilles Walsh, we must tighten the screws alternatively using 2 fingers only, 2 fingers technique, so as not to use too much force and break the graft. Number 3, the third point, we must confirm that the graft is not overhanging beyond the glenoid edge to avoid arthritis. If we'll do this, we will avoid the main complication of bone block procedure. So what does the evidence-based medicine say? A recent systematic review of 145 studies comparing arthroscopic Bankert repair plus remplissage versus bone block augmentation for managing anterior shoulder instability with bipolar bone loss, published in the Journal of Arthroscopy this year, found that both procedures are effective in managing anterior shoulder instability with bipolar bone loss with comparable outcome, but there is higher recurrence rate in case of Bankert repair plus remplissage when the glenoid bone loss is more than 10%. Another review article advised glenoid bone reconstruction for any glenoid defect, and the patient age and activity level must be put in consideration before decision making. The heel sacs lesion can be properly managed either by remplissage or by the use of glenoid reconstruction augmentation procedure instead. Another multicentric study of 26 surgeons from the United States advised that the indication of Laterjet are not only glenoid and humeral head defect, but also duration of symptoms, number of dislocation, and revision stabilization. The complications of Laterjet procedure are summarized in this table and are mainly due to technical error during surgery. The most important are graft fracture, graft resorption, non-union, and arthritis. I would like to present 2 cases. The first case, a 23-year-old male basketball player, 5-time dislocation with anterior glenoid deficiency and the small heel sacs. His CT showing anterior glenoid deficiency and the small heel sacs. And this is his CT after being operated by Laterjet procedure after 3 months, showing good position of the graft and graft union. And this is his video after 3 months. He has near full range of motion. He is pain-free, internal rotation, external rotation, and he even didn't start rehabilitation. He didn't do rehabilitation. Another case, the second case, is tramadol addict patient, and he had more than 30 times dislocation. He was operated using Laterjet procedure, and the post-operative period went smooth. But at 10 days post-operative, he had a tramadol-induced convulsion with graft fracture and screw bending, as we see here. He was managed by revision using iliac crest graft without attacking the heel sacs, as the glenoid arc increased enough to be bigger, larger than the heel sacs index. Here his CT 3 months post-operatively, showing good position and union. And he has a stable shoulder and a very good range of motion. This CT 3 months post-operatively without any case of subluxation or dislocation. So, is there a superiority of one technique on the other? A very nice systematic review and meta-analysis published this year in the American Journal of Sports Medicine on 4,540 shoulders, 3,917 Laterjet, and 623 free bone block. They found the recurrence of instability on term of recurrent dislocation, subluxation, and apprehension was less in Laterjet procedure than the free bone block, yet this difference was statistically non-significant. Also, in terms of complications, there were no statistically significant difference between both methods except for the donor side morbidity in the free bone block procedure. So the conclusion that both methods are effective and safe in managing anterior shoulder instability with bipolar bone loss and there were no significant difference in the rate of instability, recurrent instability, complication, progression of arthritis, and return to sport between the two methods. Finally, I would like to thank you for your attention and wishing you a very successful meeting. Thank you.